Okay, so I will speak about the review and update on antiretroviral resistance, and we hope that after this activity, the learners will be able to describe the principle and the mechanism of HIV drug resistance and the impact on particular mutations, select appropriate patients for genotypic testing, and describe appropriate initial therapy in the setting of pre-existing viral resistance. These are my disclosure. And we know that the goals of HIV therapy is that we should have durable viral suppression. And we have the FDA guidance, the DHHS guidance, and also the recent IAS-USA guidance. So this is what is the goal of the treatment. But we also know that when the people living with HIV on Earth do not achieve the durable viral suppression, they can develop resistant mutation to one or more components of their regimen. And this is the reason why we are here tonight. So luckily, you know that we don't have, unluckily, a vaccine against HIV because this virus is very variable. But luckily, we have a lot of drugs that have been developed that can hit almost every step of HIV replication. And we started with the reverse transcriptase inhibitors, the nucleoside reverse transcriptase inhibitors. The first was zidovudin. We have 9 approved. We have after 6 non-nucleoside reverse transcriptase inhibitors. And we have, after the other class, very important, that changed the history of the treatment was the protease inhibitors. And also we have the integrase inhibitor that is quite a recent class in the last years that can inhibit the integration of the HIV DNA on the host genome. We have the entry or attachment inhibitors like Maraviroc, the new drugs that a little bit later also Dr. Bensing will speak, that are very important for the multi-drug resistance, imalizumab or fostensavir. We have the fusion inhibitor, and also a new mechanism of action, also very important, is the capsid inhibitor lenacapavir. So the goal is to achieve the viral suppression. Today, we have really modern, potent regimen, and at least this is our experience in Italy, that more than 95% of people living with HIV after the first-line treatment achieve the virological suppression. You can see in the left how is the difference of this achievement during the time. And in the right, you see the drug experience people, more than 20,000 now that are in the ICONA court. And you see that in the beginning, unluckily, how many patients have the virological suppression, -50, you see in the light blue, very few patients, and slowly by slowly, with improving of our treatment, we have now the majority of individuals are living with HIV below 200 copies. So we, during this time, since the discovery of the first AIDS cases and after the identification, isolation of the virus, we didn't have in the beginning the treatment. After 1987, we have the zidovudin as the first drug to use as a monotherapy. After there was a development of new nucleoside reverse transcriptase inhibitors, so we can we were using with a sequential monotherapy. After was very important the dual nucleoside therapy. 1996, we have the first protease inhibitor. So we started with the protease inhibitor, but frequently were sequential monotherapy because the patients have already resistance to the previous drugs, and after also with a new non-nucleoside reverse transcriptase inhibitor. So in that period, even if a patient was highly adherent, unfortunately, since the drugs were with low genetic barrier and not so potent, and so we had the problem of sequential monotherapy very frequently, we have a lot of selection of multi-drug resistance HIV. And which was the outcome on that time? We knew that the drugs have a very low tolerability, high number of pills, and which was the facing of the clinicians at that time. fighting against opportunistic infection, death, and during the time also the side effect like lipodystrophy. In the late 20s, we started to have early initiation of therapy with better treatment, with high genetic barrier. And so today we have very much less selection of resistance viruses, even if patients, when they fail, is depending which drugs, they could fail with resistance. But we have improved the co-formulated regimens in one pill. We have the development of, from 2007, this new class of integrase inhibitors, very important. And from 2018, we have new strategy like dual regimen or long-acting. So today, the clinician is facing a better, for the people living with HIV, the better quality of life, increasing survival, aging, and comorbidity. So it's very important that for the success of a treatment, this depends on personalized medicine, which depends, of course, on having accurate diagnostic tests that identify patients who can benefit from target therapy. And this is true particularly also for HIV, where we should have not only the maintenance of the viral, achievement of the virological suppression, but also the maintenance. And so the durability is the very important concept that is depending from three actors. The patient, of course, the person is living with HIV, that is depending from the adherence and the CD4 levels, and also the drug that have two components, drug levels, so that can have drug exposure, can provide adverse effect, but also the genetic barrier of the drugs, so the number and type of mutation that are required for resistant development. And after, the other actor, very important, of course, is the virus. Virus that we can think about the baseline mutation. Subtypes is not so much influencing, but in some cases for some specific drugs, regimens, yes, and we will hear later also. And the resistance mutation that can be transmitted also will be discussed about this. But also it's important the baseline burden, how much virus, high viral load, how much also HIV DNA, that is meaning how many cells are infected. So, of course, all these viral parameters could be very important to have a success of all the regimens. HIV, we know, has a signature of a vast genetic diversity, and we have 4 groups, and the major group with the 9 pure subtypes. And today we have more than 100 major circulating recombinant forms. And we know that there is a high variability, 20–30% between the clades, and intra-decade 10–15%. So regarding the quasi-species, is a very important phenomenon when we have a chronic infection. That is meaning that when we have an individual infected for a long time, there is a continuous evolution of the virus as a result of spontaneous mutations and selective pressure. This is due because HIV is RNA virus, like all RNA virus, and particularly for the reverse transcriptase enzyme, we don't have the proofreading correction. And so this is the reason that we can have an accumulation of mutations. So when we should do the genotypic resistant testing? So first of all the guidelines, different Americans, the IAS Society, the DSS, the European guidelines, also the Italian. So all of the guidelines, national, international, European, recommended the genotypic resistant test for the choice of antiretroviral therapy in clinical practice, both for the naive patients and the drug-treated. So which could be the take-home message of these guidelines? First, that genotypic test is recommended at entry into care for person with HIV to guide the selection of the initial antiretroviral therapy. And genotypic testing should not also delay the ART initiation. We know that now we started with this procedure to have the test and treat, that in some country, in some area, you can do similar in the same day, but in Italy, frequently we do after some weeks or 1 week, 2 weeks, but anyway, it is recommended that if we want to treat as soon as possible the individuals that has the diagnosis, we could do, and after readjust the treatment according to the genotypic test results. HIV drug-resistant tests should be performed to assist the selection of active drug whenever a person is with a virological failure. Normally, with the no longer acting regimen, we should do the resistant test during the person is still taking the prescribed medicaments or within the 4 weeks after discontinuation, because we know that after the interruption of the treatment, they change the scenario. Another important that whenever we are speaking about failure, and particularly for individuals that have more than a history of previous failures, it's very important to do the current drug-resistant test, but also to evaluate all the previous resistant tests to be considered for constructing a new regimen, because we have to acknowledge and to know about historical resistant testing for the archived mutation. And the guidelines say that, so the genotypic test is the test that we should perform, but in some cases, particularly when we have multi-drug resistance, highly treatment experience, when we have suspected complex drug resistance, phenotypic resistant test is recommended and could improve the knowledge. So far, we always did the HIV RNA genotypic resistant test. Now, in the new guidelines, it's also mentioned that in principle, we can do also the proviral DNA genotyping that can be useful in people with multiple virological failure, unavailable resistance history, or low-level viremia at the time of switch. And these are the guidelines of the European, and you see that still there is a concern about the cautious how interpret this test, and we could have not always find in the DNA previous resistant test mutations, that were before in the plasma, or we can detect a clinically relevant mutation. So therefore, routine provider DNA genotyping is currently not recommended in Europe. A similar message is also in the America, in the HHS guidelines that is in the last version, where they have a topic, a paragraph speaking exactly about the optimization on the switching of individuals. Today, the majority of our individuals are with the virological suppression, but many of them have previous failure with previous resistance. So again, also here in the American guidelines, you see that in individuals who have experienced multiple prior failures or have a prolonged history of prior regimens, or you don't have the previous resistant test, it may be appropriate to utilize provider DNA genotyping test. But also here is very the important message that the results should be interpreted with caution. And so the useful of this assay in the clinic is still under investigation and has yet to be fully determined. So just to remember that in US, particularly for the initial treatment, the guidelines recommend to do the resistant test to searching for resistance mutation in reverse transcriptase and protease. Only if there is a suspect on resistance also for integrase strand transfer inhibitors, it is supposed to do the resistant test also on the integrase gene. And for the failure, again, normally the first test should be against the reverse transcriptase and protease. And again, of course, if a person fails, and now the majority of individuals anyway are treated with the integrase inhibitors, particularly for the first line, but of course, not all the individuals are treated with the integrase inhibitor resistance, drugs, inhibitors, but if they are treated, of course, it's very important whenever there is a failure to the integrase inhibitor, we need to do the integrase resistance test. This is a new part that as a recommendation in the European guidelines that whenever we know that we are using a lot now the PrEP, And of course, there are individuals that are failing the PrEP, and so it's very important to change the PrEP to a triple drug regimen, including a third drug with a high barrier to resistance. This is our recommendation, the EACS, and to start, and after, of course, to have the resistance test, and according to the resistance test, also to adjust the treatment. So if we speak about HIV drug resistance, you see a peak around 2004 to 2015. We had really more than 400 publications per year. So it's a very hot topic. Now there is a little bit decline because, but still, we have more than 100 publications each year, okay? Because still the issue of the resistance is important. And if we speak about resistance, what's meaning? It's meaning that we have the virus that is able to replicate also in the presence of the drug. And the emergence of resistance is an inevitable consequence of incomplete suppression of HIV, but this is true also for other viruses. And normally we have changes that are in the relevant part of the virus genome mutation. So I like to show this old slide from Professor Richman that was for hepatitis B virus, but this is the same also for HIV, for any viruses, that if we don't have a good antiviral drug selection pressure, we have always a virus that have some advantage that can survive and will be the fittest. So this virus could reproduce, this virus during the production will generate mutation, and the mutation will increase the genetic diversity. So we have this increase of quasi-species, and so this mutagenesis is replication dependent. So we know that all antiviral drugs normally can select resistance, and this is also true in vitro. So how drug resistance arises? Frequently, we can have virus susceptible to the drug, but we can have in some individuals, some HIV variant resistance to the drug. And so this is other reason why it's very important to don't use monotherapy. We need always to use drugs that combine more targets. And if we have a person that have, even if little amount of resistance variant, of course, there will be the selection increase and growth, and this virus that is resistant will become predominant. And when HIV replication is not completely blocked, when we have, particularly in the past, suboptimal therapy regimens, and we did in the past, unluckily, many first-line monotherapy. And we could have also adherence problem or pharmacokinetic problems. So another important point is that HIV can make an escape to antiviral pressure, not only for the intrinsic property of the virus, but also this depends from the characteristic of the drugs. So we speak about genetic barrier, that is meaning number of mutations required by HIV to develop a full resistance virus. So we have drugs with low genetic barrier, and normally the efficacy of these drugs can be lost by a single mutation or drugs with high genetic barrier, where we have drugs whose efficacy is lost after sequential appearance and selection of a substantial number of mutations. So we should remember that the first therapeutic regimen is crucial for the success of the following regimens. And so, of course, we need to limit as much as possible the use of drugs against which the virus has already selected primary mutation. And this is when was the trial for the approval of efavirenz, you see that indeed, if individuals have baseline NNRTI resistance, there was a markedly reduced virological response. You see, 9% can have virological suppression against who didn't have baseline resistance, that of course achieve virological suppression. So the issue of transmitted drug resistance is very important, was in the past, but unluckily is still very important and present. We will see also other new slides. So what we learned from the past also, that particularly NNRTI resistant mutation can persist for many years, okay? And we know that if we start a treatment with a person that have resistance mutation, of course, the response is low, particularly if we have monotherapy, but if we receive more than 2 active drugs, the response is better. In this graph, we have cartoons that show us the difference between the acquired versus transmitted resistance. You see that if we have an individual that has wild-type viruses, but still quasi-species, so not really resistance viruses, if the pressure is not good, of course, we can have a selection and emergence of resistance variants that will be selected during the therapy. And in the past, when we didn't have new drugs, we interrupted the treatment to allow the reemergence of wild-type viruses. And this we found out that in few months, the virus became, as a major population, again, the previous wild-type origin virus. But if an individual fail a treatment and can transmit the virus, of course, will transmit drug resistance. So we have individuals that have already initial resistance virus, and so the reversion to our wild-type during untreated chronic infection needed years, and this is what we find frequently when we do the resistance test. And this is the reason why we should do the drug resistance at early as possible when we make the diagnosis. And it is depending if an individual has in the first transmission, in the initial phase, of course, we could have more resistance. But if we have a late diagnosis, like with the AIDS already, of course, we can presume that the individual was infected many years before, we could have less resistance to C. So due to the intrinsic characteristic of the virus, we need to remember that we need to prevent the emergence of resistance and how the mutation can accumulate. So when we are speaking about drugs with a low genetic barrier, for instance, for NNRTI, the first generation, we know the K103N was a single mutation. And in that case, we can speak why this is very fast procedure, because we have selection of minor resistance variants that can be already present before. And so a single mutation pre-existing the therapy can be selected until inconsistent, we should say, antiviral pressure. So the wild-type virus will go down while the low amount of the resistance will emerge, and the virus will be all resistance, and we will have the failure. A different is when we are using drugs with high genetic barrier. So it's meaning that we need more mutation. So in that case, we need selection plus generation, and this will allow the development of resistance. So here we have wild-type the virus that could have a minor virus that have a single mutation that is not resistance, but is different from the wild-type virus. So if we don't have a really good pressure, all the green, the real wild-type, will be deleted, but can survive the yellow with a single mutation that will provide an added value. An added value only under the pressure, because without pressure will win in the fitness the wild-type. And here, this virus can replicate slowly, but the fitness is not so good. So it can make another mutation. And after making other mutation, finally, we will have a virus that is resistant, that will accumulate the mutations that are necessary to provide a good fitness, and so there will be the failure. So the issue of transmitted drug resistance still persists, and we know from different regions in US or in Europe, we have ranges from 4 to 19%. And normally, the most common resistance is to nucleoside reverse transcriptase inhibitors, particularly first generation of nucleoside reverse transcriptase, and after also to PI. Here is a meta-analysis that show how many studies have published and how many people. You see 32,000 people in the period 2014-2019, and more than 40,000 people from 2009-2013. So you see a trend of drug resistance that in some country, like in Europe, was decreasing. In the United States, in North America, is increasing. Upper income Asia is increasing. and also in sub-Saharan Africa is increasing. So this is an important issue. I like very much this slide because this slide say to us, even if an individual has transmitted drug resistance, if you choose a correct regimen, so that is all active, according to resistance test, the individual that have resistance will behave, the risk of virological failure is similar to the individual that have no resistance. While if you treat the individuals with drug that has a resistant transmission, not with a full active regimen, this person will have an increased risk of virological failure. And this was true particularly also with when you are treating the person with 2 NRTI and 1 NRTI, also a little bit you see that there is a change even if the fully active regimen was. So there was a risk more than if you were treating with the protease inhibitor. So this meaning that we thought that this was associated also with minority variants that could have an impact on virological failure. Today, what about the prevalence of transmitter resistance to integrase inhibitors? Because all guidelines recommend, suggest as a first-line integrase inhibitor treatment. And we need to remember that transmitted HIV drug resistance can threaten the efficacy of antiretroviral therapy, but also the pre-exposure prophylaxis. The good news that the transmission of HIV with integrase inhibitor resistance is so far a rare event. We don't have a high percentage. So this is our European analysis from France, Greece, Italy, Portugal, and Spain. You see that the prevalence of integrase resistant transmitted is 0.30%, while NRTI resistance was around 6%. This is the recent data about US, where you see that the resistance to the integrase inhibitors is less than 1%, 0.8, 4% protease inhibitors, 7% NRTI, and 12% for non-nucleoside. What is important is that you see in the US, even if here the time is 2018, the last visit, you see an increase of the M184 per year, even if it's low, it's less than 1%, but still you see a 12.9 increase. So the conclusion of this paper is that it's very important to continuing the population level monitoring of INSTI and RTI mutation, especially for the M184V, that is warranted amidst expanding use of second-generation ISTI and PrEP. This is again our Italian data that show how in the beginning, when we didn't have really potent drugs and we used for many years sequential monotherapy, the majority of the individuals that fail with resistance, okay? Many 3 or 2 classes. Very few patients fail without resistance. Today, the majority of individuals, if they fail, few failures, and if they fail, the majority of the individuals fail with no resistance, 0, because we use drugs with high genetic barrier. But still, we can have mutations, 1 class or 2 classes, and very few with the triple classes. Why is important this? Because in the past, when we didn't have new drugs in 2005, people that have multi-drug resistance to at least 3 classes have a high risk to death, while individuals that have no resistance or just 1 class or 2 classes have a better chance. So this is important that we need to prevent failure, and for this reason, new drugs and new classes of antiretroviral drugs, particularly for high treatment experience, are essential. And again, this shows to us that when we do the resistance test, and even if we have multi-drug resistant 3 classes, and we provide a regimen that is fully active, we have a good response. While if we have triple resistance and unluckily we could not choose a proper treatment, we have a higher probability of virological failure. And Another important point is, like also the DHS guidelines make now, that we have very frequently switch strategy for virological suppressed people. And so it's very important to know a complete health history, particularly with HIV viral load. And we need to think about the duration of viral suppression and the type of mutation, the historical genotypic resistant test. And in some cases, we could also think about resistance detected in proviral DNA, when particularly we don't have the information or we know that there is a particularly complex study. So here in Italy, we do a lot of PBMC genotypic resistant test, and indeed we prove here that if we combine the interpretation of previous historical resistant test plus the DNA test, indeed we have a better response to prevent virological failure if comparison if we just use the previous plasmatic RNA. So we have an experience to have an increased request of HIV DNA GRT in clinical practice, you see in the years. And this is what we see also, that the resistance is quite stable, okay? So you see that around 30% there is any resistance, and for each class we have the persistence. So, but what's meaning the persistence of archival resistant mutation? Here is a very elegant first study by the French people that show that if we have in the RNA historical mutation, like for instance 184V or 41L, you see that in the DNA, after some years, some of that mutation disappear, okay? This is at DNA level, so you see that some persisted and some disappear. And this has been done with the ultra-deep sequencing. And again, this is a recent update of this type of study, where they show that indeed in some individuals, the archived M184V disappear, but in other patients, there was a persistence, 33%, and the association of the persistence was more on treatment-experienced patients with longer pass replication under TTC or FTC, and the lower CD4 nadir and long history of ART. Another important message, so of course, is how the M184V can have an impact on people that switch to dolutegravir 3TC. That is a very used now treatment. And indeed, we see that if individuals have M184V, but in the past more than 3.5 years of viral suppression, the risk of virological failure is less than if we have individuals that have in the past M184V, but is less than 3.5 years. So more recent detection of M184V and previous resistance to more than 3 drug classes were the factor significantly associated with virological failure after switch to dolutegravir 3TC. So my last part is about Sanger or NGS. So far we used the Sanger sequencing, particularly on the plasma HIV RNA, and detect normally mutation with a frequency greater than 15–20%, so the major quasi-species. With the next generation sequencing, we can detect virus and mutation with frequency lower than 0.1%, so what we say as a minor variant. And we know how in the past was very important for the first generation of non-nucleoside reverse transcriptase. So we know now that this ultra-deep sequencing can improve the detection of drug resistance also in cellular DNA from HIV-infected patients with suppressed viremia. Indeed, these are people that have highly treatment experience. So if you see the bulk RNA, the gray lane, are the genotypic historical RNA resistance. And here you see the orange, the ultra-deep sequencing, 1% DNA. So you see that at the end, the ultra-deep DNA with the minority, so 1% is what is more close to what we find as historical RNA. In the past, we knew several studies that show that NNRTI minor variant had an impact on virological outcome. But now there are different studies on investigating the minority variants on PI. There was no impact on virological outcome. On PI and NNRTI, few studies and no impact on virological outcome. Now we have more than 25 studies investigating NNRTI ART. And so some, like we knew before, had an impact on virological outcome, but not all have an impact on virological outcome. So there is a big debate about the minority variants for NNRTIs, depending also which is the cutoff. So we have also evaluation now. We are thinking about evaluation of transmitted drug resistance by next generation sequencing that could provide an help on global surveillance studies. So can be very important. So there is like a conclusion that today, particularly low frequency variants can be important, but still we don't know the clinical significance. So my conclusion is that we have the genotypic resistant test that is a cornerstone, very important, based on plasma HIV RNA, and we use this for prevention and management of failure of antiretroviral therapy. In individuals under virological control, or also with low-level viremia, GRT on blood or PBMC, so the DNA at the HIV DNA level can be done, is feasible, and can represent a valuable tool. However, the test is not yet recommended in guidelines because we need still to understand the real clinical significance. We know that next generation sequencing based GRT testing is becoming the new standard, not only research, but also in clinical monitoring and TDR surveillance. Imagine now that for SARS-CoV, the NGS allow to do the SARS-CoV surveillance. So the NGS really now take over, and many laboratories are using NGS, at least in Italy, and I think also in US. And the NGS, next generation sequencing, allow the detection of low abundant drug resistance. However, we still need to define which are the clinical relevant cutoff of minority variants to predict the virological failure. According to the specific mutation, very important is the mutational load, how is the viral load, if it's high or low, and different drugs and specific drugs according to the different genetic barrier. Very important is that we have ART with novel mechanisms of action that play a critical role of people that are bearing multi-drug resistance, and Dr. Vensing will speak in few seconds about this. That is a very important fragile population, the high treatment experience that has at high risk of clinical progression and death. Another important issue that we have the long-acting strategy that is really changing the scenario of treatment and prevention for HIV infection. So we have new drugs, and we should always think that we have also an evolution of HIV resistance profile that is follow, of course, the improvement in regimen setting. So I conclude acknowledging you for the attention with this very important African proverb that if you want to go fast, go alone. If you want to go far, go together. Thank you very much.